Good afternoon, everyone, and welcome to our webinar on leading a new era of health data stewardship. My name is Maureen Kelly, and I'm the Director of the Health Data Stewardship Initiative at CIHI, and I'll be your MC for this session. It's my pleasure to welcome you to the first of several webinars that will focus on data stewardship and pan-Canadian efforts to build a modern coordinated approach on how data is accessed, shared, and used across the country. So while people are settling in, just a few housekeeping items to mention. All webinars, including this one, are available in English and French. To listen in French, click on the globe icon, and if you don't see it straight away, you can click on the plus sign. As well, we have closed captions are available, and you can select the Show Caption button at the bottom of your screen. This webinar is being recorded, and a link to the recording will be emailed to you about a week after our session. When you've joined this session, you would have been automatically muted. You're still able to ask questions, and we're encouraging you to do so. We'll have some time towards the end of the webinar to answer your questions. But at any time, if you have a question that you want to add, put your question in the Q&A button at the bottom of your screen, and we'll get through as many as we can during the session. And with that, I will pass things over to CIHI's President and CEO, Dr. Anderson Chuck, who will begin with a land acknowledgement and introduce our opening speaker. Andy, over to you.
Great. Thank you so much, Maureen. Before we begin, I would like for us to all take a moment to reflect on the lands we are all calling in from. At CIHI, we acknowledge and respect the land on which our offices are located. In Ottawa, it's the traditional unceded territory of the Algonquin Nation. The Toronto office is located on the traditional territories of the Wendat, Anishinaabeg Nation, and the Haudenosaunee Confederacy, and the Treaty Lands and territories of the Mississaugas of the Credit. We acknowledge with respect the traditional territory of the Kanien'kehá:ka, where the Montreal office is located. And in Victoria, we acknowledge with respect the traditional territory of the Songhees, Esquimalt, and the Wisenek peoples, whose historical relationship with the land continue to this day. We recognize that these lands are home to many diverse First Nations, Inuit, and Métis people. We also recognize the responsibilities that come with being a pan-Canadian steward of health data and the role we play in supporting systems that help historically excluded or misrepresented Indigenous peoples. We are committed to the work of reconciliation and advancing cultural safety and humility in health systems. This starts with learning and unlearning, so we can co-create relationships with First Nations, Inuit, and Métis right holders, uphold data sovereignty, and transform data for shared wellness. And now to the webinar. First, I just want to take a moment to thank everyone for taking the time out of your busy schedules to join us today. We are just absolutely thrilled to have such a strong turnout from across the country. And today we're going to discuss what data stewardship is, and why it is an important cornerstone of the transformation we need to make so that data can be used to fulfill its full potential of individual care and benefits to the broader public. Real progress will depend on how we come together as partners to share, govern, and use data differently than we have done in the past. We have a great panel discussion lined up for you. But first, I am very pleased to introduce Silvester Komlodi, Deputy Minister of Health, Seniors, and Long-Term Care, Government of Manitoba, who has joined us to provide some opening remarks. A bit of a bio, which is not going to do him justice, but with extensive experience across government sectors, Deputy Minister Komlodi previously served as the Deputy Minister of Finance and Intergovernmental Affairs for the Government of Manitoba, and as Associate Deputy Minister of Health, and held senior leadership roles in fiscal management and capital planning within the Treasury Board Secretariat and other roles in the Finance Department. Silvester's career spans various management and analytical roles in the federal and provincial public service and crown utility levels, focusing on immigration policy, energy policy, and federal, provincial, and international relations. With that being said, Deputy Komlodi, thank you for being with us today. Over to you.
Thank you very much, Andy, and I really appreciate the invitation to provide these opening remarks. Good morning or afternoon, everyone, wherever this may find you. I'm speaking to you from Treaty 1 territory. I'm the homeland of the Red River Métis here in Manitoba. It's just an honor to be here with everyone and our panelists as well. I'd like to spend the next few minutes providing my perspective as a provincial deputy minister of health and why we need data stewardship and why we need the Canadian approach that CIHI is leading. I will also highlight some activities here in Manitoba that we can contribute to this Canadian initiative. I think it'll be no surprise to hear that for today's health systems and tomorrow's, data is a critical resource, and we need data stewardship to fully unlock its power. Fundamentally, it's about improving the lives of patients and ensure the sustainability of our healthcare systems. Patients need to have information travel with them as they go through the care journeys and to have better access to their health data to empower them in their decisions about their health. Their care providers need that information so that they can provide safe, high-quality care. And for those like me who have responsibility over our healthcare system, we need good data to manage and improve our system, whether it's enhancing access and supporting the healthcare workforce. As inflation, along with our growing and aging populations, continue to drive increases in health costs, we need innovation to help make our health systems sustainable. Those innovations and new discoveries, whether it's AI or more traditional methods, at the end of the day, rely on data, good data. But today we have trapped data in silos. I think it's fair to say across the countries, often within our jurisdictions, even within sites in some cases, with complex and inconsistent rules, processes, and these things limit data sharing and use. This is a fragmentation that essentially lowers productivity. It slows innovation, increases costs, resulting in poor outcomes and poor quality of care for Canadians. While there are lots of technological advances underway, many of the underlying challenges are not technical. They are related to organizational, governance, and human factors. Some call these adaptive challenges. And this is where data stewardship comes in. We need to make data more easily available to those who need it and ensure safe, responsible, and transparent use, done in ways that reflect the expectations of all Canadians. And today we need to work together across the country to be successful. At the recent conference of the Deputy Ministers of Health meeting, where we endorsed CIHI's data stewardship model, framework and governance model, we committed to working together to drive the changes we need in policies, practices, and culture to be able to use our data more effectively to improve our healthcare systems and to learn from one another. CIHI's role is leading and coordinating these efforts, and that is essential. And in Manitoba, we're making progress and have experiences that may benefit others as well. So I'd like to take just a moment to share some of those. In 2018, we established a provincial information management and analytics shared service. This organization within our ministry is tasked with managing our health data ecosystem, integrating health data systems within a provincial data repository, and leading data governance efforts. This new organization works with Shared Health Manitoba and our other health authorities to advance our health data environment and enable more rapid modernization of our shared data assets. We've renewed and amended our data sharing agreement with CIHI to ensure our joint capability to implement the most advanced data collection, submission, and reporting systems that CIHI is developing. We've worked with CIHI to expand the coverage of data from visits to emergency departments, one of the most stressed parts of our system. We're partnering with CIHI to explore new and innovative approaches to sharing more timely information so that information is available more proactively when it is needed. Integrating data across our province and across the spectrum of care from primary to acute to long-term care is essential and must be done with care and with precision. One major data advancement Manitoba has achieved and has been successful is the collection of race, ethnicity, and indigeneity data, REI, in hospitals as part of our efforts to measure gaps that exist in access, experience, or outcomes, and inform actions and interventions to reduce racism, to eliminate racism, and ensure equity in care provision. That project was led by Dr. Marsha Anderson, and it is showing that there are critical differences in healthcare experiences, such as wait times, which we can now work on addressing. The teams leveraged CIHI's foundational work on data standards, but also customized the data to Manitoba's context, allowing more detailed and specific groups of interest. Critical to the initiative's success was the focus on significant prior engagement with Black, Indigenous, and other communities and inclusive governance of the data to ensure the safe and ethical collection and use of this very sensitive information, especially among patients that are often marginalized or discriminated against. This is data stewardship in action. We have many learnings which we can apply to the collection of other health equity data and share with other jurisdictions as they work to advance their ability to have data to address health equity issues in their system is unfolding. These are just a few examples in my jurisdiction, and I know there's more great work already underway in others that would benefit the whole country. The Data Stewardship Initiative, with its new governance model, will allow for better alignment, coordination, and collaboration, and we'll be able to achieve great things. Ultimately, I think our goal is clear: to build a health data ecosystem that is secure, high quality, connected, timely, and trusted. This requires ongoing conversation, thoughtful policy development, and continued commitment to data stewardship. I really want to thank CIHI for their leadership on data stewardship and for this webinar, so we can explore this new vision of data stewardship and learn more about the positive impact that robust health data stewardship can have on individual care and health systems as a whole. Again, thank you for the opportunity to bring these high-level remarks, and I look forward to the rest of the conversation. I will now hand things over to Brent. Thanks again.
Thank you, Deputy Minister Komlodi, for your remarks, for your leadership, and for making the case for data stewardship. Good afternoon, everyone. I'm Brent Diverty, CIHI's Vice President, Data Strategies and Statistics. I have the pleasure of moderating the panel today. Before we get to the panel, I'm just going to give you a very brief overview of the data stewardship work that the Conference of Deputy Health Ministers asked us to lead to help set the context for the discussion today. So, health data stewardship is about unlocking the power of data while ensuring it is used responsibly and transparently. I think we can all agree there has never been a more important time to come together as a country around health data stewardship. Over the last 18 months, CIHI has talked with a variety of health data stakeholders about data stewardship and their vision for the sharing and use of health data and information for patient care, for health system management improvement, to support public health and research and innovation. And what has emerged are some hallmarks of what good data stewardship should look like. These are summarized on this slide. I'll just give you a moment to read them. So one of the key deliverables from our early work is the data stewardship framework, which is summarized here. This framework outlines 9 components of data stewardship that need to advance to make the vision of improved data stewardship a reality. Some of these components, like the ones on the left-hand side, address more strategic aspects of data stewardship, focusing on changing the overall environment and the conditions for data use. Other components, those on the right-hand side, focus more on operational aspects to ensure that day-to-day handling of data is safe, efficient, ethical, and transparent. Across the bottom 2 components that are weaved into all the others, ensuring support for and alignment with First Nations, Inuit, and Métis data principles, including sovereignty and governance structures, and also public trust and engagement, ensuring that patients are at the center and our approaches to data reflect public values, needs, and expectations. The full data stewardship framework, developed over the last 18 months with extensive consultation, is now available on CIHI.ca. We welcome you to go visit the site and dive into all of the materials that were there. And as Deputy Minister Komlodi mentioned, the Conference of Deputy Health Ministers endorsed this framework at their September 2025 meeting. As Andy mentioned in his remarks, progress will depend on how we come together as partners and as a community, as Canadians really, to share, govern, and use data differently, more effectively than we have in the past. This slide presents our agreed upon governance model, also endorsed by the Conference of Deputy Health Ministers in September. I'll quickly walk you through this one. So nested under 2 existing FPT committees, the one for public health data and the one for digital health and health system data, we have a couple of new entities that we're establishing. First, a collaborative consisting of FPT representatives and others that serves as a key forum for identifying data stewardship priorities and advancing solutions that span across jurisdictions and sectors. Supporting the collaborative will be a multi-interest panel, bringing diverse cross-sector voices into data stewardship governance to help the collaborative shape priorities, provide equity-centered advice, and ensure inclusive, consensus-based input. We'll set up some task and finish groups that are time-limited, expert-driven teams to address specific stewardship challenges that the collaborative agrees to tackle. And finally, coordinating all this effort, CIHI will serve as the national or pan-Canadian nerve center, so to speak, for data stewardship, with dedicated responsibility for strategic coordination, alignment across pan-Canadian priorities, and integration of inputs from across the ecosystem. And of course, tracking our important progress as a nation together. The intent of this model is to ensure that stewardship moves from a concept to something operational and actionable. And with the framework and governance model established and endorsed, we're now moving full steam ahead into implementation, working with partners. Some examples of what is happening now include, first, standing up the governance structure and the membership of those and developing the multi-year stewardship action plan for endorsement at the first meeting. Second, continuing with data stewardship work underway, and including our so-called driver projects. Some examples include supporting the interoperability roadmap work led by Canada Health Infoway, the immunization data priorities, Public Health Agency of Canada, and supporting health AI readiness across the country with many partners, including Health Data Research Network Canada. Third, continuing to build out the framework, providing resources and support such as training modules to build data stewardship capacity. And finally, continuing to focus on engagement, ensuring it's embedded in all the work and that it reflects public values, needs, and expectations in a meaningful way, including First Nations, Métis, and Inuit groups, patient groups, and the public. So data stewardship's a journey. It's a journey of partners and one we will travel together. We're very excited to be at this point. And so now we're going to turn to our panelists for what I know will be a great discussion about the journey ahead. So let's meet them. So first, we have Laurie Proulx. Laurie is a patient partner, a strong advocate for patient perspectives for many years. I think they'll be joining me on screen. There's Laurie. Welcome, Laurie. Next, we have Dr. Verna Yu. She's the Provost and Vice President Academic at the University of Alberta. And she's also CIHI's board chair. So welcome, Verna. And last but not least, Dr. Kimberlyn McGrail, Associate Dean of Research at the Simon Fraser University School of Medicine and the Scientific Director and CEO of Health Data Research Network Canada. Welcome, Kim. So panelists, we're going to get into the questions, and maybe as you answer the first question, I'd certainly invite you to take a minute or so to provide a bit more of an introduction to yourself, but we'll get started. And Laurie, I'm going to start with you. One of the key shifts in our data stewardship approach is instilling a duty to share. What does that mean to you, and what do we need to do differently?
Great. No, thank you so much, Brent, and thank you for having me here today and having patients that have incorporated, as you launch these frameworks and new priorities and that sort of thing. That's super important. I've been a lifelong patient. I was diagnosed with juvenile rheumatoid arthritis when I was 14. So it's hard to remember a time when I wasn't navigating care, trying to, the system, medications, and you name it. But when I think about your question, really about the duty to share, and I think we all clearly recognize that, when we think about sharing data, it's to support better clinical care, and that's really well understood. I think clinicians need access to my health history to care for me safely and effectively. But sometimes I don't think we talk enough about the other side of that duty, and that patients too must have real ownership over their data. And that means having a say in who sees our information, when they see it, and how it's used beyond our immediate care. And I think that conversation is largely missing. I know this past summer, I had the privilege of co-facilitating some focus groups, in supporting CIHI, as you were developing these frameworks and these plans. And I think what we heard through some of that from the patient partners, the 20 or so that we talked to, was that people don't necessarily oppose sharing. They just want it to be meaningful and not necessarily automatic. So the question's not, should providers access our data, but which providers for what purpose and sort of under what conditions. And when we look at consent, and, it's often sort of treated as a bit of a checkbox, lengthy legal language that people don't realistically read or understand. But I think this emphasis on stewardships, has us, gives us an opportunity to do better, to build plain language tools, usable consent models, and let patients express preferences in ways that make sense to them. And I think too, we need to recognize that the data isn't always accurate, and patients experience misdiagnosis, incorrect notes, unchallenged assumptions in their records. And most records can follow them through the system. And so I think if we want the data to be actionable, we need to, incorporate patients to, into the governance, into all of these things, have the ability to review, question, and correct their data. But I also think the duty to share means sharing information back with patients themselves. Patients, we don't really have that much control over much, right? We've been given a diagnosis. We live with these conditions. We have no control over it. We don't have access to the therapies or supports we necessarily need. So I think accessing it back gives people some agency. And so it enables that understanding and sort of making decisions that make sense to them. And so I think it's, the duty to share isn't just about moving data through systems, but it's about building trust by recentering patients as stewards, not just spectators, sort of their own information at the end of the day. So that's my thoughts on this question.
Great. Thank you so much. And it's so great to have you with us. Just before I turn to Kim with the same question, I wanted to know we've got 458 participants on the call. That's a great turnout. And I'm noticing some people are using the reaction buttons, and there's been some hearts and some claps and things. And we certainly, in addition to the Q&A later in the webinar, we just encourage everyone to interact. And there's some claps right there. Perfect. Great demo. Thank you. Well timed. Okay, Kim, over to you.
Great. Thank you. The pleasure to be here and happy to be part of this. And I really appreciate Laurie's opening comments. I'll just build on those. From a slightly different perspective, I agree with everything Laurie said, but my background is in the use of these data for research purposes, so more the population level use rather than the individual level use, and both are essential. And I got into this work on building research infrastructure and data stewardship because I was so dependent on the data for my own research purposes. So started as a little bit, I guess maybe could be seen as somewhat selfish kind of way of getting into an area of work. But I really have enjoyed the experience of trying to work with the public for public input on data practices and being involved in lots of other ways. So in answer to the question about what duty to share means to me and what we would need to do differently. So I think of duty to share as a bit of resetting the default, where as I see, and again, this is maybe more particularly in a population level data use situation, but I think it probably applies generally, is that right now we have a culture of I would like to have access to data, and the answer is no, unless you can show me that you have all these things and you can have all these protections and do these things and make these commitments, as opposed to, yes, you can have access to those data as long as you can show that you have these. And that maybe seems like a very subtle, small difference, but I actually think it's pretty fundamental. If we're starting from a framework of thinking the answer is going to be no, and there's a high bar to get over, as opposed to, yes, I would like to share, but I want to make sure you're going to do things with the data that you're receiving in an appropriate and safe way. So I think that what that means is that duty to share is only feasible if there's a number of other things in place. For example, as has already been said, we really need to make sure that we do this in a way that respects data sovereignty. And that means First Nations, Inuit, and Métis peoples, nations, but it means data sovereignty for Canada as a whole, which is something we've been talking about quite a lot about this past year. It means data sovereignty for provinces and territories and other groups who will contribute data, because some of the data that we want in the health system comes from the private sector, insurance providers, and all sorts of other things. And I would underline here that sharing does not necessarily mean moving data around. And some, like what Laurie was describing, in some cases, people just need to be able to view information. They don't necessarily need to have it in an ongoing way. So there's lots of ways that we can think about sharing, even what we mean by that. We would also need to reduce variations in practice. Like we have a lot of different ways of doing things. I'm sure we'll come back and talk about this a bit more. So we have the same legislation in some cases and interpret it differently. So if we want to have a duty to share, we're going to really need to have some more common practices in that. We absolutely need to build trust. And some of that trust is about the public understanding and supporting what we're wanting and needing to do with data. But it's also things like building trust between research ethics boards and having the ability to have one project and one review for that project so things can move more quickly. And that kind of relates to another thing, which I think is we need a bit more proportionality in the data sharing and use space. And what I mean by that is there are some basic things when I speak with public and clinicians and all sorts of other people, it's very clear that there's some things that everybody expects that we're doing that we're not. So these are simple things, obvious things that we should be sharing. If I go to an emergency room, somebody should have access to the information about me, the most basic things. So proportionality would mean we let those things that we know should be done happen and happen quickly. And then we spend more time worrying about the things that might challenge the edges of the system or that might be a new thing that we haven't talked about before. And then the last thing I think is we need to all have a commitment to ongoing evolution. There's no way that the rules and the way we set data stewardship today is going to be right 10 years from now. And I think just our last few years of experience with artificial intelligence would suggest why that would be the case. So this is not a one and done. This is not, we're going to get it right, and then we're just going to live with this from now on. We have to be able to move together as things evolve and as more things are possible. So that's, I think I'll leave it there for now. Thanks.
Thank you, Kim. And Verna, over to you for a quick introduction and your thoughts on duty to share.
Yeah, thanks very much. And just apologize for my cold. So I might cough intermittently, but just to say, prior to my role here at the University of Alberta, I actually was the president and CEO of Alberta Health Services at a time when it was the integrated provincial healthcare system for 6+ years. And one of the things that we did that continues to this date was to launch a on time and on budget provincial EMR. And the vision for the EMR, as the Deputy Komlodi had mentioned around data stewardship, was really the importance of ensuring not just improving health outcomes for Albertans, but improving financial sustainability and long-term sustainability of the system. And just to Laurie's point, which I thought was really important, the vision from a patient perspective as we rolled out the EMR, which we call Connect Care, so it's a bit of a common theme with the CIHI Connected Care, was really to enable putting the patients at the center of their healthcare team by enabling them to access their data, which they should be able to access and which they own. But it also provides them with the opportunity to then be at the center of the healthcare team instead of being on the sideline. And being able to invite providers into their health journey with the ultimate goal of improving the journey as well as improving the health outcomes. So with that sort of premise, really when I think about duty of share, it really means shifting from a culture of where we have already noted from some of the other panelists, Kim in particular, was really, the fact that right now we tend to protect the data by withholding it. As Kim said, sometimes, we go into, when we ask for data, we automatically assume that the answer is going to be no. And it's around protection of data, patient privacy, versus really trying to use the data responsibly for individual care and public benefit. And it acknowledges when we actually want to share data that, data only has value when it's actually used. There's no value to it when it sort of sits in a database and nobody's able to access it. As I said, it improves care, it supports equity, it strengthens system learning, and it benefits Canadians. When we focus on the risk of sharing, we often think of it from the context of the risk of not sharing. And so when we think about that, we always think about, well, if we share it, what is the risk? But what if we don't share it, and what are the risks associated with that? So, for example, we don't share data. Not only are we going to miss invaluable insights that could impact on clinical care and clinical outcomes, there's no doubt in my mind it would result in poorer outcomes. There would be inequities. And this is not only from an individual perspective, but also at a system level. So when we move forward, what does duty to share require? It requires clear governance and accountability, so organizations know when and how they can share data. It requires standardized tools, agreements, safeguards to make sharing easier, more consistent. It really requires a culture shift so that we treat data as a shared asset and not as a siloed resource. And as Kim has said, we really need to build trust with the public. So ensuring that sharing is transparent, is ethical, aligned with expectations and patient rights. And the last one I want to add in there is that it really does require something we don't talk a lot about, but which is health literacy. We need to support the public in understanding what their health data is, how to best use it to not only improve their health journey, but to improve their health outcomes. So with that, I'll pass it back to you, Brent.
Okay, thanks for that. And we're off to a great start here. So I'm going to move to the next question. Earlier in the webinar, I had a slide up that showed the 9 components of our data stewardship framework, those needed to drive improvements in how we share and use data. So they're guiding principles and culture, legislation and legal agreements, data strategy, data governance, stewardship skills and literacy, data management, data use, First Nations, Inuit, Métis data governance and sovereignty, and public trust and engagement. I just went over that intentionally again because it was a few minutes ago we did that, but maybe I'd ask each of you, starting with Verna. These are all important, obviously, there's no doubt about that, but if you had to pick one to focus on, what would it be and why?
Yeah, I think that if I had to pick one, it sort of is the foundational element, which is really around the guiding principles and culture. Because at the end of the day, if you don't actually have those entities, the principles and the culture, as we know, this is kind of the North Star. It actually shapes every decision we make, who gets access, how are risks managed, how do we bring people along. And so without that shared culture that's grounded in equity, in partnership, transparency, and Indigenous data sovereignty, the other components won't be fully realized. So really, and it really is probably the hardest one in my mind, because it's not transactional. It actually has to be built over time. Mm-hmm. And it requires a lot of relationship building, and it requires a lot of trust to know that we can get there together.
Thank you. So Laurie, same question. What's your top pick for focus area?
Yeah. So, very much. And I think I echo many of the comments already from my fellow panelists, Verna and Kim. I really saw public trust and engagement as really the sort of hinge point for everything else. You can have a lot of the other things, advanced systems, careful governance, but if patients or the public or caregivers don't trust the system, I just don't think the data will flow in the ways that truly enable that sort of improvement. And so, and I guess it kind of goes back to why would people share their information if they don't believe it's going to be handled responsibly or used in ways that will benefit them or their communities at the end of the day? And I think we've kind of talked a little bit about this. It's not just kind of a one-time thing, as like Verna said, it's not a transactional thing. It's a relational and ongoing thing. And it's actually quite hard, right? Because, for many communities, distress reflects real historical harms. And so it really needs to be grounded in accountability and respect. And that's like the Indigenous communities, the others. I saw a comment in the chat from, the 2S LGBTQ, but there's also many other communities, right, that have experienced inequity, right, who aren't seen, that need to trust, these processes, and because they haven't always been treated well. And I think it's just really fragile, right? It's something that's earned. It's shaped by how health data is treated across the entire system, not just what a single organization will do, right? So every sort of situation where it hasn't been respected, means it's damaged and it's very difficult to sort of rebuild. But I think an opportunity really is to kind of take it from the abstract and kind of go back to like showing tangible outcomes for people. Like, how is your data used? And how did it, affect your care, give you better access, gave you better equity and accessing what you need. And then it's not just sort of reports, right? It's things that'll have a meaningful impact on you and others in your community. So, and I think there's a few things we can do. We can, embed patients to have a real voice in how their data is used, like all throughout, from governance, decision-making, priority setting, across all of the sort of jurisdictional and the CIHI coordinating center, being really explicit and transparent about how data is used for community benefit. And kind of moving away from like extractive models of data use, I'll call it that, right? It's like, here we've collected all this information, but we don't give you anything in return, right? So I think it kind of goes back to that, longstanding, philosophy, I'll say, in the disability community, the nothing about us without us type of thing. So I think there's lots of opportunities going forward to make these things more real and live and relational. And so that hopefully we can, gain the benefits, right, of all this data being stewarded and used to people's benefit at the end of the day. So.
Great points. Thanks. Very well said. Kim, what's your top pick?
Yeah, this question's pretty challenging because I really think that the framework was designed to be a whole piece. So you really have to do all of the things in the framework, and you have to do them all well for this to work, which I think is consistent with what Verna and Laurie have already said. But I'm gonna pick the one that I would describe as where the rubber hits the road, and that is the stewardship skills and literacy, because this is the implementation and actually enacting the kind of framework in its real day-to-day operations. So, and I picked this one in part because stewardship is an immensely shared responsibility. So if we think about all of the different organizations and institutions and private sector partners and individual doctor offices and all of those things across the country, it means that we have thousands of people across Canada who will have a role in data stewardship. They'll be a data steward, or they will work with a data steward, or they'll be making decisions as a delegate of a data steward. And so a common understanding of the roles, the responsibilities, and the accountabilities is the only way we're going to be able to go anywhere with this. If we can have a great framework, we can have great plans for this, but if we get down to it and every single one of those thousands of data stewards interprets things in a different way or wants to do something very particular to their organization, things will fall apart a little bit. And if they start to fall apart, it's going to be a recipe for potentially losing trust, because it will not look like we have a common approach to this across the country. So this is really about building a community that has some kind of compatible orientation to data stewardship and an understanding of that, ability to navigate what will be sometimes complex requests or situations, maybe sometimes challenging, maybe sometimes things that could or should be done but have some perceived risk to their own organization, which might change their view about whether they want to have those things done. And they'll also have to have a lot of trust in how other people are doing their similar roles, and ideally the ability to trust that others' decisions can be your decision as well, not because you're abdicating your responsibility, but because you believe other people have the same orientation to you and will identify the same risks and opportunities. So, and I do think that there's a close relationships between this and this kind of idea of data stewardship and literacy and respecting data governance and sovereignty, because it's a good understanding of stewardship and literacy that will include understanding how we meet our obligations for honoring sovereignty, in all its different forms across the country.
Great, thanks. Some common points and some unique points there from everybody. Thank you for that. So we're going to move on. I'll also say to the audience, we're in about 5 minutes. We're going to turn to your questions. So just flagging that for people, and still enjoying the reactions that are coming up around different points that the speakers are making. So please continue to engage with us. So Kim, we're going to start with you here. The Health Data Stewardship Framework and Governance Model emphasize a pan-Canadian approach, working collectively to achieve consistency and coordination across the country. One might say this is another, to some degree, change from past attempts to improve the accessibility and use of health data. So why is it important that the whole country does this together?
Yeah, and I think some of the comments I just made are really part of this as well. So this framework is not setting up a hierarchy. There's not going to be one charged person sitting somewhere in the country who has ultimate control over everything, and that they're at the top of a pyramid and can just command and control the way the rest of the system is going to work. That's not what's designed here at all. And there's not even a single person within each province or territory who will have data stewardship over everything, because we are talking about a very large and diverse set of actors in all of this. And so, but we do have common things. We have a common Pan-Canadian Health Data Charter, which puts people at the center of both the design and having input into things. And now we have this data stewardship framework. So we can work with that overarching framework, common purpose, common practice, trust, and reciprocity. And that does mean that working together is critical. This isn't going to work if we don't work together. And I think in part of that, the way that we can keep ourselves working together is by keeping in mind that ultimate accountability for all of this is to the public and to people who are represented in the data. And we're doing the things that we are with data in order to ultimately improve health and health equity in the country. That's it.
Thanks. And Verna, so your thoughts on the importance of a pan-Canadian approach?
Yeah, so just to follow up on what Kim just said, when we look at health and healthcare, we know that doesn't follow jurisdictional lines. Patients move across Canada to live, to work, diseases across boundaries, and health systems are increasingly interconnected. We also have a federally delivered health services and an increasing number of independent Indigenous health authorities. And so, as we know, data doesn't cross these boundaries. And so without coordination, we risk fragmentation. There'll be inconsistent standards, definitions. There's going to be duplicated work and barriers to really the connected care. And a really good example of the struggles that we had when we didn't have any of this was during COVID-19, right? COVID was a huge issue for the country because we didn't actually have any data that actually helped us. And so we saw how PHAC had to run backwards. CIHI, I know, had to put a lot of additional effort into it. And so we've got to be smarter, knowing that there's going to be another pandemic coming, much to all of our chagrins. And so let's really make sure that we've got that collective stewardship. And so when we think about a pan-Canadian approach, we, as I said, need consistency in how data is governed and shared. We need to make sure that happens now. There's got to be that interoperability across the provinces, territories, and systems. We've got to have shared learnings so that we can learn from what's working well and that we aren't reinventing the wheel, and better support for national priorities as it relates to things like immunizations, workforce planning, especially safety and equity. And if you think back to the pandemic, all of those are so important to be able to deal with something that's such of a global entity. And it also strengthens Canada's position globally as it relates to health data innovation. So ultimately, collective stewardship is more powerful than isolated efforts. And I think we need to be smarter coming out of the pandemic.
Thanks, Verna. And Laurie, your thoughts on a pan-Canadian approach and its importance?
Yeah, I mean, I was going to say the same as Verna in terms of, we experience healthcare. It's not just, by jurisdiction, right? Like we're moving, and we should be. We might move for work. We might, be somewhere else and need that set of support. We have communities in remote areas, right, that regularly need to travel outside of jurisdictions, quote unquote, because that's just the way people need to access healthcare. And so I think, to her point, we need to sort of follow up with the data to support them. And I might just add in terms of, there are different sort of approaches, right? Different privacy laws. And I think Kim kind of spoke to that, or consent processes. And I think we need to maybe think of these things more broadly as well in terms of that sort of cross-jurisdictional collaboration, because we, as patients of the public, right, we expect a certain sort of set of norms or processes to be followed regardless of where you're going for that. So I think that's like an important area that could be, addressed. And I just think, again, to your point, Verna, in terms of being able to leverage the data and show those impacts back. I mean, when we think of rare diseases and when we think of so many of the health inequities, like I'm immunocompromised, right? And for example, we don't have as good a data on vaccines, right, in my population, right? Because we weren't part of the trials. This is where research and secondary use of data can be so valuable and really give us information about us, right, as people from coast to coast to coast, right, not extrapolated from some other, source at the end of the day. But I would also say, it's a call to action as well to incorporate patients in all of these different decisions, right, from the governance. That, it's something that needs to be built into that sort of national coordinated approach. So patients, can be able to influence data policies and uses, those feedback loops I was talking about, to show the value, to build the trust, right? And to make it so it's not just symbolic and possibly tokenistic, but meaningful, right? So that we can build trust and not erode it, right? Like, I think that's super important, and our success, I think, really hinges on that. So.
Great, thanks for that. Now I've been scanning the comments and questions from the audience, so just a couple reflections there, and then I'll turn a few of these to the panelists. So many people talking about in different ways the critical importance of involving patients and considering patients in all this work. And I think lots of comments there and some good advice from people on the call. So thank you for that. There's a question here. Maybe I'll turn this one to the group. I mean, there's an interesting one here about the cost of not acting, of not improving data stewardship and having data more accessible and better used for care for patient, to support patient access to their record and for system uses in research. Because maybe just a couple reflections from you. I'll start with Kim perhaps on this one. The cost of not acting. What are we losing?
So, I mean, to some degree, I think what we're experiencing now is the cost of inaction. So we have systems that are not integrated in a real way. So it's if you're lucky enough to have a primary care physician and only need a primary care physician, your care might be very, very good. Once you start moving through the system and need to go to see specialists in primary care and you get admitted to hospital, you might need some rehab. You might have to pay out of pocket for some things. Your information isn't necessarily flowing, and if you have a primary care physician, they don't necessarily always understand everything that's going on. And that is, if we think about continuity of care has three pieces to it, three dimensions. One is the relationship part. So we want to get the relationship part right. Another one is management continuity, and that means that we have a care plan for somebody. We understand what's needs to happen with them, and it's clear who's responsible for what. That needs some work. And then the third piece is information continuity, because to support those other two things, you really need to have the information flowing from one provider to another. So this is what we don't have right now that we could have if we had better patient flow in that sort of clinical individual level use case. And then on the population level stuff, we're missing out on innovations. We're missing out on understanding our system as well as we could. We're missing out on developing new things that we could be doing. We're missing out. My friends who work in clinical trials would want me to say we're missing out on clinical trials. Canada used to be a far bigger player than we are now in that space, which means that we're missing out on access to new medicines and being able to do things that we could do with our diverse population. We could do with the kind of data we have, but we just don't have the system set up to do them properly.
Great. Look to Laurie or Verna. Do you want to get in on this one? So the opportunity costs of inaction.
Maybe I'll just add, because we, in fact, when we actually went to government to support our electronic medical record system for the province, part of it was to show what we call the values benefit realization of what do you do if you actually don't go ahead and you don't actually have that type of electronic, integrated record system. And there were numerous examples. And so this is actually fairly well documented across different EMRs that have rolled out. They've actually shown sort of tangible outcomes of the reduction, for example, in duplicative testing, reduction in variation of care, reduction in sort of medical errors. And so when we actually try to put sort of a values amount to that, because that was obviously really important to government, you can imagine also important to the health system to show an ROI. Over the 10-year period, it was something like this is a $1.2 billion rollout. Government invested $400 million. And I think the benefits realization was about 1.7 billion over the 10 years between hard savings and soft savings. Most of it were soft savings, but it was really important to demonstrate that a lot of times we don't put the tangibles out there, but there are definite tangible outcomes when you actually don't have access to the data. And I think, Laurie, when it comes to a patient perspective, the individual's experience is really important also, but that's really hard to pull out to really justify investing in something like this. So I just wanted to share that with the group.
Thanks, Verna. Laurie, anything to add?
Yeah, I think there's just lots of opportunity costs, and to bring it kind of back to patient perspectives. And I also work as, part-time with a patient organization called the Canadian Arthritis Patient Alliance. And every day I'm talking to somebody who has some unmet need. And sometimes we don't understand the most fundamental things, right? Like some of the, vaccine side effects, maybe access to healthcare services for French-speaking communities in Ontario. There's all these different things that we actually don't have data. And I'm often emphasizing that, there is opportunities for grassroots action for players outside of typical systems as well. So I would ask that we consider that. And that to me is often like a missed opportunity to maybe not sharing the data, or sort of kind of to somebody's point, using a more participatory action research approach. Is it could be really seized, I guess, if we were to free up the data and link that data back to sort of the grassroots real needs of patients who are living this reality every day. So
Thanks for that. I'll acknowledge the questions that are coming in here. I think there are and lots of comments and advice and things as well. So thank you for those. I think there may be a few of them where the CIHI team might follow up with the specific answers. I want to take the panel to the closing section here. We're just a few minutes from time though. And there's actually a question in the chat that aligns with the question I was going to ask to wrap up. So we'll kind of combine them. It really is just maybe I'll ask each of you, starting with Laurie. So a single action that needs to be taken, soon to move this forward. I think that's what we'd be looking for here. And as I said, that kind of combines what I was going to ask you with a question here, which said, what's a concrete thing we can do in 2026 to advance this? So Laurie.
No, I think my call to action is simple, and I've already kind of covered it. I think we need to be building trust by putting patients and the public directly into governance and decision making. It's not just policies, strategies, or one-time consultations. It's meaningfully inputting them in those roles to be heard, to help shape the priorities, to help build that trust, right, around how health data is stewarded and shared. And it's not, trust isn't just built by collecting data, but by sharing that sort of power and privilege with others.
Kim, what's your call to action?
I mean, just to start by echoing what Laurie said, we have the Pan-Canadian Health Data Charter. The first two principles of that are, one, that we have person-centered data design, and the second one is that we have ongoing and meaningful input from the public into data use, so data stewardship. So that's one, and provinces and territories have made commitments to the Health Data Charter through their bilateral agreements with Health Canada. So that's that, we should take that and run with it. And then it's implement the data stewardship framework. The framework is fantastic. It just needs to be, make sure that for CIHI to make sure the right people, inclusive people around the table to do it. But the framework is there, and we just need to get it going.
Thanks. And just before I turn to you, Verna, I'll just mention for the audience, probably should have done this in my remarks, our work is grounded in the principles in the Health Data Charter. So there's no, just because I didn't mention that, I should have. There's no disconnect there. In fact, that's the inspiration for the work that I talked about today. Verna.
Yeah, I would absolutely agree with Laurie and Kim, and having that patient be embedded in whatever that we do is really, really critical. I can tell you that when we rolled out our provincial EMR system, patients were not just the sidebar. They were at every table. They were often leading the tables or co-leading the tables. And I can tell you that they added tremendous value. And I think sometimes in the health system, we get a bit patronizing that, we're the experts, we know what's best. But, they were fundamental to the creation of the provincial EMR. And we are so much better for the system that is now completely rolled out across Alberta because of the patient voice that was embedded in the governance framework. So I just want to say that that's really, really important to make sure it's present at all different stages. And often having them co-lead it is actually invaluable. And lastly, I just want to say, remember, this is a long-term journey. And I think if we can agree to work collectively together, there's a lot of things that we can do as a country in building the type of system that we want.
Perfect spot to end this conversation. Thank you so much to the panelists. I really appreciate your thoughts, your wisdom. And I'm going to turn it over to our CEO, Andy, for a few closing remarks.
Great. Thank you so much, Brent. And thank you to all of our panelists, Verna, Laurie, and Kim, for such a thoughtful conversation. It's really been a privilege to listen and learn today. A couple of themes come up for me. There are so many destinations that the data needs to get to, but without cooperation, agreed to mechanisms for the safe use and sharing, getting there will either be too slow or maybe not get there at all. So how do we connect and agree to the mechanisms in a federated country with 13 plus health systems within each jurisdiction as well as across them? This is at the core what stewardship is, right? Stewardship at its core is the means by which to establish the agreed to mechanisms that enable the safe and trusted flow of data the patients need. And we know that if we have healthier patients, that will only result in a better sustainability of our health system. But here's the thing. This is not a technical fix. It's a culture shift. Duty to share is going to absolutely be key. And we heard clearly today that one of our most powerful resources is data, but its value only comes out if we can actually access and use it responsibly. So to be successful, the transformation of our health data ecosystem can't just be about technology and systems. It really is a change in culture and mindset. And knowing that a duty to share doesn't diminish privacy or data protection, it actually complements it. You just have to recognize that if you don't share data, that also comes with its own consequences. The second insight was that trust is going to be foundational to changing mindset, right? Trust must be earned through transparency, integrity, and meaningful engagement. It requires clear communication and a clear understanding by Canadians about why is this data important, why it matters, how is it going to be protected, but also how is it going to benefit them, right? It also requires respectful partnership with First Nations, Inuit, Métis organizations that are grounded in sovereignty and self-determination. Trust can't just be a byproduct of status stewardship. It's really a measure of what it means to have good stewardship. And then the last one is just that we need to really do this together. This work requires collective leadership. There's no single org that can do this by itself. patients move across systems, data needs to cross boundaries, and we really need to be able to enable innovation to happen everywhere. And so no one health system can fully realize these benefits in isolation. Now that we have this framework and a solid foundation for change, the task now is really to make it happen. And so maybe with as a final reflection, to make it happen, we should all just remember that data stewardship is not something that you just do. It's not a checklist and you check the box and you say, oh, we're finished. It's really an ongoing practice that we have to embed in our culture. It requires leadership at all levels, openness to do new things, and a commitment and will to continue to progress on this and do what's right for Canadians. Just speaking for CIHI quickly, we're definitely honored to lead and support this. And with that being said, maybe I'll throw it back to Maureen, and thank you again to everybody for joining us today.
Just before we go, I just wanted to share that if you want to connect with us in a bit more detail, please, we've got our framework and lots of other resources and materials on our website. Visit us at CIHI.ca, or you can scan the QR code. We will be having another webinar on February 19th where we'll do a deep dive into the framework and all of its details. And if you have any further questions, please email us at datastewardship@cihi.ca. And so finally, again, I'd like to thank our panelists, Deputy Minister Komlodi, Brent and Andy together for joining us today. And thanks to everyone for taking time out of your busy schedule to be with us today. We'll send a recording out in a week or so. And thank you very much and enjoy the rest of your day.